Hello everyone, and welcome back to the Medical Entrepreneur IV Chelation Training Series. I'm Adam Sewell, MD, and this is video A3, where we'll be taking a closer look at the major chelating agents used in IV therapy. Before we begin, let me emphasize our disclaimer. All information shared here is for educational purposes only. It does not replace personal clinical judgment, local regulations, or official practice guidelines. Always consult the appropriate references and professionals when considering IV chelation therapy. If you haven't watched video A1 and video A2 yet, I recommend checking them out first to understand the basics of IV chelation and heavy metal toxicity. Now let's get started. A chelating agent is a substance that binds to metals in the bloodstream, creating a complex that the body can excrete, usually via urine. Different chelators have varying affinities for different metals, so selecting the right agent for the specific metal toxicity is crucial. In this video, we'll be focusing on the most commonly used chelators in IV therapy. 1. EDTA, ethylene tetraacetic acid. 2. Dimercaprol, British anti-Lewisite, BAL. 3. DMSA, Succimer and DMPS for Penicillamine. 5. Deferoxamine. Let's go through these chelators one by one, discussing mechanism of action, major indications, and potential side effects you need to keep in mind when delivering IV therapy. 1. EDTA mechanism of action. EDTA binds to divalent and trivalent metal ions, most notably lead, but also calcium, iron, and others. Clinical indications, primarily used in cases of lead poisoning, often paired with dimercaprol for severe lead encephalopathy. Administration notes, typically given via slow IV infusion over several hours. Key considerations, can cause hypocalcemia because of its strong affinity for calcium. This is why we often use calcium disodium EDTA instead of the disodium form. Regularly monitor electrolytes, renal function, and ECG. 2. Dimercaprol, BAL. Mechanism of action, a sulfur-containing compound that binds lead, arsenic, gold, and mercury. Clinical indications, often used in combination with EDTA for severe lead poisoning with encephalopathy. Also indicated for acute arsenic or mercury toxicity. Administration notes, traditionally given intramuscularly, IM, but IV forms exist. Adverse effects can cause hypertension, tachycardia, and pain at the injection site. It has a notably unpleasant odor as well. 3. DMSA, Succimer, and DMPS. Mechanism of action, these are water-soluble analogs of dimercaprol that form stable complexes with lead, mercury, and arsenic. Clinical indications, DMSA, Succimer, is often used orally for mild to moderate lead toxicity, especially in children. DMPS can be used intravenously for mercury and arsenic toxicity. Advantages, generally better tolerated than dimercaprol with fewer side effects like injection pain and blood pressure changes. Caution, still require monitoring of renal function and metal levels. Hydration is key to aid in excretion. 4. Penicillamine. Mechanism of action, binds copper and certain other metals. Clinical indications, primarily used for Wilson's disease, an inherited condition causing copper overload. Also indicated for cystinuria and, less commonly, heavy metal toxicity. Potential side effects, allergic reactions, cytopenias, like low white blood cells or platelets, and possible kidney issues. Clinical tip. Although it's sometimes mentioned for lead or mercury, other agents are often preferred due to better side effect profiles and specificity. 5. Deferoxamine. Mechanism of action, high affinity for iron, forms ferrioxamine, which the body eliminates. Clinical indications, acute iron poisoning, for example, overdose on supplements. Chronic iron overload, seen in patients needing frequent blood transfusions like thalassemia major. Administration notes, can be given IV or IM, often used as a continuous infusion in chronic cases. Monitoring, must keep an eye on blood pressure as hypotension can occur during rapid infusions. Watch for allergic reactions and potential changes in vision or hearing with long-term use. So those are our main chelating agents. Knowing which agent to use and when is essential for safe and effective treatment. Remember that using the wrong chelator or administering it incorrectly can lead to dangerous side effects or ineffective therapy. Here are a few key considerations when choosing a chelator. 1. Metal affinity. Each chelator targets specific metals more effectively. 2. Patient factors, age, comorbidities, and whether the patient can tolerate IM versus IV routes. 3. Side effect profile. Weigh the risks like hypocalcemia, EDTA, blood pressure changes, demercaprol, or allergic reactions, deferoxamine. 4. Monitoring, regular labs to check metal levels, kidney function, electrolytes, and more. That wraps up video A3, major chelating agents. In our next segment, we'll dive into clinical protocols and patient management, where you'll learn how to safely administer these agents, monitor patients, and handle complications in real-world scenarios. If you have questions, feel free to leave them in the comments or discussion forums. Thank you for watching, and I look forward to guiding you further in this medical entrepreneur IV chelation training series. Until next time, I'm Adam Sewell, MD, and I'll see you in the next video.